Rajan. Okay. So, on behalf of the organization of Peculiar Series, Case Series in Renal Transplant, I invite you for the 27th meeting of Peculiar Case Series in Renal Transplant. I once again thank the members who have been a constant support for us to conduct this program for the past 26 months without any break. And this is our 27th program. And I'm sure that time spent today will be a fruitful one because it always imparts important knowledge sharing among the transplant physicians regarding the peculiar cases and how to manage this. As usual, this session will be taken care of by two talks by two speakers. Going to be a really new one this session, and the panelist for this, I'm very much happy and proud to introduce our panelist for this sessions. Dr. Vishwanath, he's a professor and HOD of Department of Nephrology, Manipal Hospital, Bangalore. And he's not new to this forum. He has already adorned this forum twice as a debater and as well as a speaker. And this time he comes as a panelist to share his knowledge on these two important peculiar topics that's going to follow. And he has a lot of publications, 25 publications on his regard. And he has a lot of transplant experience. And you might be knowing from his peculiar case series group, where he will jump into the help whenever some questions have been put regarding the complications and management of different cases. Joining him is Dr. Pratik Das. He's a senior consultant nephrologist from Ramindranath Tagore Hospital. Now it's Narayana Hridayalaya Hospital, Kolkata. And he, along with Dr. D.S. Ray, is running a mill of transplant, around 20 to 25 transplant per month. And he's specialized in ABO incompatible transplant, retransplants, and now many complicated transplant. He's a soft-spoken and highly academic person, and who has a lot of transplant-related answers left in him. I'm sure his inputs in this forum will will make us to take many home messages, actually. So this forum, this meeting is being run by two speakers. One, I'm happy and proud to announce that I introduced Dr. Swarnalata Group from Nizam's Hyderabad, who is going to present the presentation. And ma'am has always known to many, doesn't need any introduction, and she is one of the is a professor of nephrology in Nizam's Institute of Medical Sciences, Hyderabad, and is heading the cadaver transplant program in Telangana. And he has around 69 publications, has trained around 55 DNB residents, DM residents from Nizam. And ma'am has been a good support for us in the past and the present, actually. And I'm afraid that she will be joining because she is pre-commitment and all. His senior resident, Dr. Niranjan, is going to present a case. It's going to be a novel case where very few reports are available throughout the world. And another one is by Dr. Arun Kumar, and he's a young firebrand and nephrologist from Apollo Hospital, Bangalore. And he's a vibrant nephrologist, and it seems like more complicated cases goes to him, that he does a lot of complicated renal transplants and many times come out successfully. And he's the one who did a lot of ABO transplants, including pediatric ABO transplant, highly complicated transplants. And now he's going to present very, very unique situations like rheumatoid arthritis, tonus, and renal transplant, which very few papers are available. I'm sure it will incite a lot of questions and important discussions to follow. Without wasting much of the time, I invite Dr. Arun Kumar to start his presentation.
I've shared the, I think screen is shared.
Yeah.
Yeah. Make it as a full screen. Yeah.
Let's go ahead. Yeah.
Yes. Thank you, sir. Thanks for the kind introduction, and I thank Vishwanath sir and also Das sir for being here for this talk. Sir, today's presentation is a case series of rheumatoid arthritis donors for live donor kidney transplant. And it is an amalgamation of three difficult recipients, one a politician, one an information technology guy, and a guy from media. He is the owner of a private channel in Karnataka. So I will go into the donor. The first donor is Mrs. L. She is a 68-year-old lady and married. She is a retired Hindi teacher. She is P2L2, full-term normal delivery. She comes from Bangalore North. Her blood group is O positive. She is completely euglycemic and her BMI is 30 kgs per meter square. She is a known case of rheumatoid arthritis from last 12 years. She is on regular dose of HCQS and methotrexate. Methotrexate she was taking weekly 7.5 mg and HCQS 200 BD with no previous joint deformity. Her menstrual history, she is menopause 12 years ago with no white discharge or postmenopausal bleeding. Her rheumatoid factor was 16 international units per ml. Anti-CCP was 4 international units. ESR was 42 and CRP was 20. Her ANA was negative and tests for antibodies like Smith, RNP, topoisomerase, SSA, SSP and dsDNA antigens were all negative. So we did an imaging of her wrist and also the bones. Imaging found cortical irregularity at radial aspect of the base of the first and the fourth proximal phalanges, as well as the head of the fourth metacarpal of the right hand, with normal bone mineralization and normal joint spaces. A kidney biopsy was done for evaluating because there were no other donors. So we wanted to consider her because she is the mother of the recipient. So she wanted to donate. So we did a kidney biopsy which showed minimal alteration at light microscopic level and immunofluorescence was also normal. So when we evaluated her, she was without morning stiffness, constitutional symptoms, tender or swollen joints, and was fully functional. So she was a prospectively healthy kidney donor for her son for an ABO compatible live donor kidney transplant. Her vitals were stable. Only thing that was high was a BMI, which was 30 kgs per meter square, where she falls into overweight to obese category. So going on to the labs, you can see that her creatinine is 0.9, HbA1c was 6, and her urine protein 24-hour was 46 milligram per DL. Because her serology and urine culture, everything was negative, we consider her as a donor. But however, in the DTP renogram, her split function left kidney was 49% and right kidney was 51, and her total GFR was 82.1 ml per minute per 1.73 meter square. Because he didn't have any other donor, because he was above 75 ml, we did consider doing a transplant for this patient, and we did it. And now he is 1 year and 3 months post-transplant, and his creatinine is 0.9. So second donor is M. Begum. She's 50-year-old lady, married. She's an economic professor, P2L2 full-term normal delivery. They come from Devarajeevanahalli from Bangalore North. The blood group is O positive, and her BMI is 26.9 kgs per meter square. She's also a known case of rheumatoid arthritis since 2 years with no joint deformity and well controlled with HCQS and methotrexate 7.5 mg OD. Her menstrual history, menopause 1 year ago, no white discharge or post-menopausal bleeding. Her RA factor was 20, anti-CCP was less than 5, ESR was 38, CRP was 5, ANA and all the other antibodies were all negative. So imaging was done, her ulnar aspect at a basal and the head of the fourth metacarpal on the right hand, both mineralization were sparse and the other bones were all normal. Her kidney biopsy was done before transplantation, which demonstrated minimal alteration at light microscopic level and also immunofluorescence. So her cholesterol, her triglyceride was 241. All the other parameters were all normal. So she was a prospective voluntary healthy kidney donor for her husband with ABO compatible live donor kidney transplant. When we evaluated her, she was without any stiffness, no constitutional symptoms, no tender joints, or she was fully functional. Her vitals were fine and also BMI was very good. So here 24-hour urine protein is 50 milligram and her creatinine baseline was 0.6. We have done the transplant 4 months back and her husband's creatinine is 1.2 with adequate TAC levels and he is doing well. She is also doing well. Her total GFR was 99 ml per minute per 1.73 meter square. So third lady, she's a wife of a politician and her name is Shobha Rani and she's 51-year-old married lady. She also is P2L2 from Vijayanagar. She is B positive. Her BMI was 28.5 kgs per meter square. Her rheumatoid factor was 38. Anti-CCP was 25. ESR was 49. CRP was 33. All her SSA, SSB and all the other antigens were all negative. And she is rheumatoid arthritis since 2.5 years with well controlled on only HCQS. So imaging found normal bone mineralization and normal joint spaces. And kidney biopsy done before transplantation demonstrated minimal alteration at light-time microscopy and immunofluorescence. So later, her methotrexate was increased to 15 milligram and hydroxychloroquine 200 milligram, after which she experienced complete clinical remission. And when she was evaluated, everything was completely fine, and we went ahead and did the transplant. The only thing was she had also undergone a bilateral TKR 2 years ago, laparoscopic polycystectomy 20 years ago, and laparoscopic ovarian dermoid cystectomy 2 years ago. So she was a prospective healthy volunteer kidney donor for her husband, and she also was into an overweight category. So her creatinine was 0.66 and 24-hour urine protein was 68 milligram per DL. Her cholesterol, triglycerides, everything were normal. So her total GFR was 99.89 ml. So these are the 3 donors for whom we did do the transplant, and all of them have crossed now 3 months. The longest was 1 year and 4 months. So all are doing well, including the donors. So I'll briefly go into rheumatoid arthritis and what are the complications of rheumatoid arthritis and how do we do transplant. So rheumatoid arthritis is a systemic autoimmune disease which primarily causes joint inflammation. Prevalence is around 1% in the population, with greater predominance in the women. And rheumatoid arthritis is a common rheumatological disease which can involve a variety of different renal manifestations. Chronic inflammation in RA can result into joint destruction, significant physical disability, and premature cardiovascular events. So there is a Jordanian study. Generally, every one of us will think of doing an American study first, but I'll do a Jordanian study because this study did a total evaluation of 44 patients, and all of whom they evaluated for renal manifestations. What were the manifestations? So it was predominantly in female, 88%, and 11.6% in male, totally 285 patients, and the average disease duration was 6.7 years. And age, type 2 DM, hypertension, and serum CRP were associated with worse renal functions on univariate analysis. 44 patients, that is 18.8%, presented with microscopic hematuria, that was a common presentation. 16 patients, that is 6.9%, presented with proteinuria, and only 5%, 2.1%, presented with both microscopic hematuria and proteinuria. And the patients with eGFR less than 60 ml per minute had longer disease duration, that is a mean of around 11 years, in comparison to for those who had a GFR more than 60 ml, which was 6.4 years. So longer the disease, higher the fall in the GFR. So there are 2 eras when you go into rheumatoid arthritis. One is the olden era, where the RA can affect the kidneys directly by the defect of the disease or secondary to the drug. Generally, it is biological or non-biological disease modifying agents of rheumatoid arthritis. Commonly previously used drugs were penicillamine, busilamine, gold, and cyclosporin, and also NSAIDs, which were commonly used in the previous era. And poorly controlled systemic inflammation also led to mesangial proliferative GNs or secondary amyloidosis. Japan and Korea, even now, they use older DMRDs. So hence, the direct manifestation of RA or indirect manifestations are still reported with respect to Japan and Korea. Whereas the European Union and also the American area, they don't use the olden DMRDs at present. So coming to the new era is filled with methotrexate and biological medications. There is a decrease in NSAID use, and a treat-to-treat strategy have contributed to decrease in renal functions. So chronic kidney disease in RA is now more likely to be caused by a cardiovascular risk factor than an uncontrolled RA disease severity. Clinicopathological correlation shows that most common pathological finding on renal biopsy in secondary amyloidosis, membranous nephropathy, and less commonly, it is RPRF. So prevalence of renal involvement in rheumatoid arthritis. In the era before methotrexate, that is the olden era, the targeted biologics, chronic kidney disease was common in RA patients with a prevalence of around 37 to 57%. That's almost 60%. In contrast, with systemic lupus erythematosus, clinically significant renal damage was directly related to RA is typically not observed. So, except in the case of patients with poorly controlled disease activity who may develop secondary amyloidosis, which can lead to end-stage renal disease. all the types of involvement of rheumatoid arthritis can be grouped into two. One is glomerulonephritis, the other is others. In glomerulonephritis, mesangial GN, immunoglobulin IgA, membranous GN, which is medication-induced and non-medication induced, minimal change disease, and FSGS. Whereas in others, it is interstitial nephritis, which is usually caused by NSAIDs, papillary necrosis, commonly because of NSAIDs, rheumatoid vasculitis, renal amyloidosis, and CKD, which is caused by the CVD. That is generally in elderly patients, hypertension, diabetes mellitus, and in some cases, obesity also. So I'll go one by one. So glomerulonephritis, autopsy studies in RA describe mesangial proliferative and membranous GN with crescentric GN also, although there are little or to no associated compromise in the renal functions reported. So patients who present with glomerulonephritis, if you have done a study, they have done a study in autopsy, which shows there is no alteration in the renal function, even though they have a damage with respect to glomerulonephritis. And strangely, we are taught in our PGs that is membranous glomerulonephritis is usually nephrotic range proteinuria, but in RA, it usually presents with subnephrotic range proteinuria. So coming to the second common most, mesangial glomerulonephritis, the prevalence among the GNs is 35 to 78%, and commonly it is seen in long-standing RA, that is 12.9 plus or minus 10.4 years. The common damage is caused by the interleukin-6, which is increased levels in the peripheral blood and synovia of the patients with RA, may be a growth factor for these mesangial cells. Hence, the mesangial proliferation happens and GN. Higher urinary interleukin-6 levels were observed compared with patients with primary minimal change disease. So next is membranous glomerulonephritis. Commonly, an immune complex deposition can occur in a segmental or a diffuse form. It is associated with either DMRDs, that is gold, busilamine, penicillamine, and has also rarely been described in patients with RA not taking these medications. Nephrotic range proteinuria with a shorter RA disease duration. When you have an RA patient with a nephrotic range proteinuria, you can suspect, first go into the duration. The duration is long, generally they'll present with subnephrotic proteinuria, whereas if the duration is shorter, 3.8 plus or minus 2.9 years, they would usually present with nephrotic range proteinuria. And here, the primary treatment would be discontinuation of the offending medications. Immunosuppressants and prednisolone does not significantly influence the time of remission. The next common manifestation is IgA nephropathy. Frequency of IgA glomerulonephritis in patients with RA is similar to that seen in general population. The prevalence is as high as 12% among RA patients. Histologically, it is indistinguishable from the primary or with or without RA. Usually, the mode of treatment is AC, ARBs, and steroids. But however, they say steroids does not have much role. Other diseases include MCD and FSGS, which are very, very rare, and severe necrotizing renal vasculitis with microscopic hematuria, proteinuria, and renal insufficiency with cutaneous and pulmonary involvement are also seen. Usually, such kind of RPRF pictures with vasculitis are treated with high-dose glucocorticosteroids and immunosuppressants such as rituximab and cyclophosphamide. So the most common manifestation in rheumatoid arthritis is serum secondary amyloidosis, which is usually because of the serum amyloid A protein, which is synthesized by the hepatocytes in response to pro-inflammatory cytokines like TNF, interleukin-1, interleukin-6. And it is usually associated with longer RA disease duration. Average is 17.2 plus or minus 7.3 years. There is chronically increased level of SAA, which can lead to secondary amyloidosis, particularly in genetically susceptible patients who have SAA allele. So deposit in the glomeruli, blood vessel, peritubular capillaries, and interstitium of the kidney is very common. And it classically presents with proteinuria, increased serum creatinine level, and develops progressive renal failure. So there is one Japanese study, which we can quote as an Asian study, in which a cross-sectional study of 1908 Japanese patient with RA, those with CKD defined as EGFR less than 60 ml, had a greater prevalence of diabetes mellitus, hypertension, and advanced age. All these things were detrimental for the GFR function, that is glomerular filtration rate, when compared to patients without CKD. So the odds ratio was also higher and p-value was very significant. So many studies have already demonstrated that diabetes, hypertension, and advanced age are a predilection for having a CKD in patients with RA. There is one study from the UK in a cross-sectional analysis by Dowsis and colleagues of 400 patients with RA in United Kingdom. Traditional cardiovascular risk factors such as hyperlipidemia, hypertension, and insulin resistance were associated with CKD, whereas RA disease activity, severity, and duration were not associated with CKD. So it is the concomitant hyperlipidemia, hypertension, age, and insulin resistance which contributed to CKD than the disease activity itself. So in the post-methotrexate era and post-biological era, generally the complication occurs or the CKD occurs because of metabolic risk factors, as the picture depicts, and cardiovascular disease and cerebrovascular disease. These are all contributory factors for chronic kidney disease, whereas the traditional factors, which is on the left side, inflammation causing the metabolic risk factors and cardiovascular and cerebral risk factors, are generally very sparse as of today. So this is one large article which was published in NDT, an Italian study where kidney involvement in patients with rheumatoid arthritis was studied. So between 1991 to 2001, 275 patients with diagnosis of RA were included. 48 patients underwent biopsy, and in which renal amyloidosis was diagnosed in 13 patients, membranous GN in 19, mesangial-proliferative GN in 7, focal segmental GN in 5, focal segmental sclerosis in 4, minimal change in 3, and tubulointerstitial nephritis in 7 patients. So what do we do in such donors where we have to consider them for donation, where they are the only donors available for the recipient? What do we do? How do we go forward? So there is, how should an anti-rheumatic medication be managed in a perioperative setting? One, perioperative setting, stopping of DMRDs prior to surgery may result in disease flares, and that can adversely affect the rehabilitation. And you may take the kidney and give a lot of pain to the patient in the joints. So what we do is generally, we don't stop any DMRDs, that is the methotrexate and following methotrexate era. The methotrexate is generally safe to use in most perioperative circumstances. Guidelines from ACR and also from the American Association of Hip and Knee Surgeons, which recommended that all non-biological DMRDs to be continued in perioperative setting for RA surgeries. However, there is no recommendation for transplant surgery because the data for transplant surgeries for rheumatoid arthritis donors is very sparse. So this is the only study which we could get on the outcome of living donors with rheumatoid arthritis. This is a study done in Minnesota in the Mayo Clinic. So a retrospective cohort study at a tertiary referral hospital to assess the outcomes of living kidney donors with rheumatoid arthritis. 6 adults with rheumatoid arthritis who underwent nephrectomy as living kidney donors between January 2001 and September 2014 were included. 18 non-donors with rheumatoid arthritis, that is 3 non-donors per donor, were randomly selected for comparison by matching the year of birth and comorbidity score. So this is the characteristic where the age on an average was between 30 to 64 of case 1 to case 6. Sex, predominantly the donors were female, 4 of them were females and 2 were males. And body mass index on an average was between from 24 to 36. And baseline creatinine level was 1.1 to or 0.9 to 1.4, highest being 1.4 in case 2. And baseline GFR were 52 to 85 were the average. And years of remission before donation, some were long enough, that is 45 years, and some were only 5 months. And most of them were not given any medication for rheumatoid arthritis. And case 4, you can see they are given linfliximab and leflunomide. So results of this study, none of the donors with rheumatoid arthritis had a flare-up of arthritis at a median follow-up of 5.9 years. Non-donors with rheumatoid arthritis had a flare-up at a median follow-up time of around 4.7 years. And after nephrectomy, donors' estimated GFR decreased to a mean of 45.53, standard deviation of around 4 ml per minute per 1.73 meter square at 7 days after the index date. So the estimated GFR of donors subsequently increased significant at a rate of 3.99 per minute per 1.73 meter square, which was statistically significant. and none of the donors with rheumatoid arthritis had end-stage renal disease or developed or died at a median follow-up of around 5.9 years. So healthy kidney donors with rheumatoid arthritis have good outcomes with no increased risk of decline in renal function or end-stage disease or death. So this is one more study, which is Hickinson et al. Overall, it elucidated that cumulative incidence for impaired renal function, that is defined as EGFR less than 60, was 9% at baseline, 15% at 10 years, and 25% at 20 years. So which average comes around to 6 to 7% in a year. So this is one case report, last case report, where there was a living donor for living donor donation was planned. Here the recipient had anti-neutrophilic cytoplasmic antibody associated vasculitis, and the donor was rheumatoid arthritis, where there was an active disease with a strongly positive anti-CCP and also RA factor. And this case is written so elaborate that every nitty-gritty of RA was defined, and finally they didn't do the transplant. So they have suggested that our best recommendation is to find an alternative means of transplantation for this recipient, and our recipient successfully underwent an unrelated living donor renal transplant in February 2021, and repeat ANCA status test was non-reactive at 1 month post-transplant visit. This was their conclusion. So they suggested that the RA, when there was active disease, they didn't want to do the transplant to an ANCA positive recipient. So what can we conclude today? RA donor can be utilized if the RA is under control and patient is under remission, and long-term follow-up with respect to their GFR, hypertension, diabetes, and also obesity to be kept in mind and followed up. Transplant is like going to Mars, that is Mom Mission 1. When you are doing a transplant recipient with rheumatoid arthritis, it can be complicated when you are having an underlying autoimmune condition or a disease which can flare up like an SLE, where the recipient is SLE positive and the donor is RA positive. We don't know. It is uncharted territory. And first attempt will be there for various conditions. So we can even try such approaches and try to see if we can do a larger favor for the patients who can be taken as donors. Science, self-belief, and structure approach is very, very important for taking a rheumatoid arthritis donor. Here we had these 3 cases in the last 1 year. 1 year and 5 months, and we are happy to share these cases where all the donors are doing well and recipient is also doing well. Thank you.
Thank you, Dr. Arun, for the excellent presentation of a rare series. Actually, it's a rare series, and you have successfully come out with this transplant. Actually, so many more congrats for this is one of the second series, I think. So apart from your 6 donors, actually, which was only study available, right?
Yes, sir.
And congratulations. Before start the ball to roll. So why do you need an X-ray? Actually, you are doing the X-ray for these donors. No, what is the relevance of doing X-rays to look for deformity? If deformity is there, you don't do the transplant.
No, sir. Just to have an idea whether you need to intervene just before transplant, whether ortho correction of a deformity, like for example, if they have issues with respect to their legs or mobility, then we need to correct the deformity if it is possible to correct any of them, and then go ahead and do the transplant. That is first idea. Second idea is to see if there is an active disease with respect to the orthopedic intervention. And if they have it's not that we'll not consider them for donation. It is just that to have a clear-cut understanding, and if we be able to explain to the patient that you don't have a deformity and this is the proof and things like that. And second part, it is usually more of an ethical completion process than rather actually a medical legal thing than rather a medical aspect as well.
So you do biopsy for all the 3 recipients, donors, right?
Yes, sir. I did it because there were not many case reports. So if we have a surprise in store, like for example, if they already have a kidney damage and if we take a kidney and then they become CKD, then we'll be in trouble. So to prove that there is no active damage due to rheumatoid arthritis, so I did a biopsy for all the 3 patients, donors.
Okay. I welcome Dr. Pratik Das for this meeting. Dr. Pratik, sir, your comments regarding his presentation. And
thank you very much for inviting me, and it's an excellent presentation because it is commendable to perform 3 donors in 1.5 years time with rheumatoid arthritis. As you know, you quoted the series that they have done 6 cases over almost 10 years time.
Yes, sir.
So it's commendable. So thank you very much. Just
Thanks,
when do the transplantation and evaluate the donor, we are concerned about 3 risks. The donor will land up in end-stage renal disease in some point of time. We have done everything, including the biopsy, and we have looked. Second part is whether they are at a greater risk of developing a cardiovascular disease. That is difficult to evaluate because they will be getting the medicines in future.
Correct.
Because there is a possibility that requires a long-term, you never know, they may require an intermittent short course of steroids also in between, and inflammatory milieu will be there, even though there is a possibility of. And thirdly, which I am more concerned is that regarding this, whether they have a peri-operative or anesthetic risk. You didn't comment about anything about whether any of them has a temporomandibular joint involvement, because difficult intubation, extubation, possibility of reintubation, that is a big concern, because you cannot put a patient as an anesthetic risk, whether in a difficult airway. That thing I think needs to be strictly evaluated. And another thing which I got, that there is some kind of this, because these nephrectomies are done under GS. So there is if in induction they use this nitrous oxide. So there is some amount of drug interaction with the methotrexate with the nitrous oxide. They have told that it can potentiate the effects of the methotrexate. Side effects will be post-operatively it will be much higher. So how did you tackle these peri-operative, these para-operative problems, particularly this airway, and secondly, these drug interactions with the methotrexate, the nitrous, and all this?
Sir, primarily, first, the anesthesia evaluation one was done, and we had a detailed discussion regarding the anesthesia. And after doing all the scoring, because there was no temporomandibular joint involvement, so from the anesthesia side, they told that there is no issue with respect to any involvement of the temporomandibular joint, and we could go ahead. So other than that, the second aspect, sir, to tell you frankly, we didn't discuss. Let me be straightforward and open, because this potentiation of worsening of nitrous oxide and methotrexate, I was not aware, sir. So we didn't have a discussion, sir, per se, but touch wood, we didn't have any problem with respect to peri-transplant, during transplant or post-transplant, anesthesia or recovery or anything. All of them were extubated in the OT table itself, and they were all comfortable, sir. But I could learn that point from you, that there is an interaction which we didn't know, sir, to be fair.
Yes.
thank you. Dr. Vishwanath, your comments, please.
Excellent presentation, Dr. Arun, and congratulations on your great work. And I would suggest you probably go for publication since you have biopsied. My question to you is, if there is no proteinuria and GFR is normal, though you have biopsied, going forward, should we biopsy or just see them clinically and decide?
Sir, now after these 3 cases, as you told, sir, we will like to do a transplant by just evaluating for 24-hour urine protein and then looking for the disease activity. That's all, sir. Serological and also radiological with respect to clinical. All 3 things we can look, and we don't need to do a biopsy is what I feel, sir. Even though, because there was one study which I quoted, sir, there was an autopsy study where there was GN, but none of them had a renal dysfunction. So that would be counterproductive if you do a biopsy and then you will think that, oh, there is GN, so we'll not plan to do a transplant at all. So that may be counterproductive, but the best part would be to do clinical, serological, and radiological evaluation, and then go ahead and do the transplant.
So that's one of the question in the chat. I think they have asked.
Yeah.
You're looking for clinical remission or serological remission. You're looking for both, isn't it? What are they looking?
Yes, sir. Both.
Yeah.
Sir. We're looking for both, sir.
Both, yeah.
Dr. Arun, how many? What is the time frame for clinical remission? For some months or years? Any criteria for that, actually?
Sir, actually, if they were generally considered is around 6 months, sir. If you are in remission in 6 months, they have done transplant. So as I told you, the case report which I quoted, here in our case, all of them had 1.5 to 2 years remission period. I mean, remission period. So they started rheumatoid arthritis 2.5 years back. So all of them had a minimum remission of around 1.5 years. So that's why we went ahead and did the transplant. And rheumatology team was also involved so that we don't take a decision individually. But I ideally would feel that 6 months remission would be very, very important to keep the disease under control and then do the transplant.
So suppose a patient.
What are
Yes,
your
sir.
comments on the newer one? See, methotrexate, some many newer rheumatologists, they may have stopped using. So most of them use leflunomide and tofacitinib. If you look at it now recently, there's a lot of data for tofacitinib. Most of them are on. I mean, infliximab and other things are given up. Most of the lot of complications with that, so they have stopped. So what are your thoughts on that? Many of the patients are on leflunomide and tofacitinib.
Yes, sir. So leflunomide and tofacitinib, there is a study which from the UK, which they studied for a period, but none of them are studied in transplant. So maybe the only thing that we will be encountering with leflunomide and this thing is the reduction in the total count, and probably our counts may reduce because we have post-transplant, we are going to give valganciclovir and also going to put them on immunosuppression. So those things we have to keep in mind. Tofacitinib, I have no much experience to quote about anything, sir, on that.
Some of us have used in COVID, no? I don't know.
Yes, sir. We have used right and left in COVID.
We used the only thing you need to look at hepatotoxicity, I think. Of course,
Yes.
counts you need to look at it.
Yes, sir.
Yeah, far and few.
Yes, sir.
Go ahead, Dr. Raja was asking something.
Yeah. Dr. Arun, actually, if somebody is on your patients, luckily your patients are on HCQ, and one patient you have escalated to methotrexate, right?
Yes, sir. Yes, sir.
So one thing to consider is regarding the long-term side effect. Though it is not renotoxic, lot of other than compared to other DMARDs,
Yes,
it has a slight preponderance for developing CIN, chronic interstitial nephritis.
Correct.
So how do you take this actually? And another thing, if suppose a patient is on sulfasalazine or CSA, that is a cyclosporine and all, whether you need to convert into other safer DMRDs before taking for donors, or you will be accepting them with the same DMRDs?
Sir, methotrexate, as per the data says, it is safe, is what they say.
Yeah.
So generally they use weekly once and we continue. Most of them, sir, when you stop methotrexate, they do have remission. That is, at least they develop joint pain, joint swelling, at least if it's not a florid flare of RA, but they do develop some amount of few joints having flares. So I would like to continue methotrexate, even though it is going to produce a chronic interstitial nephritis. But here, sir, one case, as I told you, the first case, she was on methotrexate for 12 years. And even in biopsy, there was nothing seen on the biopsy. So the other two cases also, there was nothing in the interstitium or this thing. Only one of them were in methotrexate. So as per the data, methotrexate is safe, is what they say. When you are going to use it continuously for a longer period, then we need to keep a closer follow-up on the donor. That is first point. The second question, sir, I exactly didn't get to the second question. The second part which you asked?
Second part is whether you will patient with on cyclosporine or sulfasalazine, which is a known nephrotoxic agents. So do you want to continue when the patient is on both these drugs, whether you want to take the donor with these drugs or you will convert into safer DMRTs? Is it safe to do transplant with this?
So always better to convert them to safer DMRDs, like whichever is feasible. Like for example, you can convert sulfasalazine and other patients to methotrexate itself. Or else, sir, as per the bridging therapy, you do have this HCQS and steroids, which you will be continuing in your post-transplant period. So steroid itself can act, as Das sir was telling, that steroid itself can have a suppressive effect on all these inflammatory mediators, and that itself can produce a little bit of remission for them. But by chance, if they flare up, then probably the newer drugs like tofacitinib can be thought about. Whereas the older generation drugs and drugs which are going to cause renal dysfunction, I think we need to stop and change them over to a newer drug.
So how do you follow up the donors actually? Is there anything you follow up the donors every
Sir, I've kept a new protocol, sir. That is what I'm thinking of following. Like we'll do a urine protein creatinine ratio at the end of 3 months for the first 1 to 2 years. Follow them up with respect to renal dysfunction and do a regular evaluation on their LF, on their lipid profile, and keep a close watch up on their blood pressure. Because as per the donor study, most of the donors who donate will become hypertensives in a span of 2.5 years. So hypertension would be a very important aspect, and allowing them to have as more salt restricted diet, and also closely following up with them with respect to obesity. these three things I'm planning, sir. One is fasting lipid profile every 3 months, urine protein, urine routine, and also RFT every 3 months for the next 2 years, and calculate the number of flares that they're going to have. If they have no flares, then we can prolong the duration after 2 years for 6 months. Once we can do the same evaluation and keep them in the loop.
Thank you. So what is your take up on CRP, measuring CRP levels before transplant? What is the serological remissions? What are the serological parameters we look for remissions? That was one of the questions in the chat box.
One is RA factor. The other is anti-CCP. If the anti-CCP is very high, sir, then it indicates that there is no serological remission. So generally the value is up to 20. If it is two times that, then probably you need to start, bring them to remission, and then only plan for a transplant if all the other parameters are okay. If there is high CRP, high anti-CCP, and also high RA factor, then we need to consider that it is not a serological remission. Generally, all the three parameters, at least two out of them, and anti-CCP being very sensitive is what they say, because CRP is not a very clear-cut indicator. So anti-CCP is used in one of the studies. Anti-CCP was used as a parameter for rejecting the donor. So which the study which I quoted, that anti-neutrophilic antibody ANCA positive donor. So they say that as per data, it is the anti-CCP which is very, very important. What we could think in our setup is anti-CCP and probably RA factor both can be considered for serological remission. So have a first recorded one, then see if there is a decrease in the titer once we give them medications.
Yeah. Any comments from the panelists?
Yes,
You're running short of time. Sir. Yes, sir. Proceed, sir. Proceed.
So when you follow up a donor in the immediate post-transplant period at 3 months' time, there is some amount of increase in the ACR is quite natural.
Yes.
And unlike that of other patients with diabetes and hypertension, they are not that dangerous. It doesn't predict your future cardiovascular diseases. Neither there is a predictor of the future renal failure. I can remember one long study. They have compared this urinary albumin creatinine ratio with, and interestingly, they have done FGF23 in the donors patient. And they compare it, those patients after 4 weeks of time, those patients having an increased ACR, they followed for next 5-6 years time. And the patients who have a slightly higher FGF23 and that is remained high in the post-operative period, chances of developing in a renal failure and the ESRD in the group which is having a persistently high FGF23 is much more compared to that of who is having an urinary ACR increase. If you follow all your patients, you can get this. There always some amount of increase at 3-6 months time, slight increase in ACR, and that remains over the years, and that doesn't goes up basically. So following a donor with a urinary ACR may not give you an adequate indicator whether he or she will be developing an end-stage disease or a cardiovascular disease in future. That is a clinical profile you are monitoring. That's fine. It's every 1 year, 5 years, 10 years time you monitor your donor by routine testing, and clinically that is okay. And that is a novel thing they did. This is I just shared it because I read it. I cannot remember where I read, but it was a very interesting article.
How often do you do this FGF23, sir? How often?
They did for the purpose of their study. Okay. We don't do FGF23. We can do it. It is available. It is not very costly also. It is a cheap investigation. Okay. But I didn't get any reproduced article after that. As I can remember 3-4 years back, I think.
Thank you. Thank you, sir. Vishnu, sir, any comments?
Nothing. Good presentation, Dr. Arun. Congratulations. We'll go to the next talk around time. Yeah.
So, Dr. Niranjan, can you please start your presentation just?
Oh.
Yeah, make it as a full screen. Yeah.
Hello, myself Niranjan from senior resident from NIMS Hyderabad. Today I would like to present a case of rare case of mononeuropathy secondary to TAC toxicity under the guidance of Dr. Sonalata Madam from NIMS Hyderabad. And I would be discussing in the following readings mainly about the donor and recipient details, case presentation, and I would like to discuss about it. Coming to the recipient details, he was a 47-year-old male resident of Hyderabad, and he was diabetic since 10 years and hypertensive since 6 years, with past history of diabetic retinopathy, with a baseline creatinine of 3 milligram per deciliter at the time of diagnosis of diabetic retinopathy, and progressed over 3 years to CKD. Native kidney disease being presumed DKD, and one important thing was he was euglycemic after initiation of hemodialysis. Coming to the donor details, donor was his wife. She was 42-year-old female, and immunological workup done, and HLA was nil match. Flow CTC was negative, and she was planned for left nephrectomy with the GFR of 52 ml per minute. The donor did not have any significant comorbidities. Coming to pre-transplantation, it was a live-related renal transplantation, and the date of transplant was 22/6/23. It was a B positive blood group transplantation, and induction was planned induction was ATG, and the dose was 3 mg per kg. Coming to the immunosuppression, tacrolimus dose was according to the weight, it was around 0.08 9 mg per kg, so it came around up to 5.5 mg, and MF was given 2 grams, 1 gram BD, and induction, that is 150 mg ATG was given, 50 mg from on day 0, day 1, followed by day 1 and day 2, and prednisone was given on day 0 of 1 gram, and followed by 500 mg and 500 mg on day 1 and day 2 according to the institution protocol. Coming to the transplantation details, it was a immediate graft function, and he was on triple immunosuppression. TAC metabolism, it was a fast TAC metabolism, and post-operative day 4 TAC levels were around 10.2 nanogram per ml. He was discharged around post-operative day 7, and the discharge creatinine was around 0.79 milligram per deciliter. He was advised to follow twice a week in immediate post-op period. Coming to the case presentation, he was presented in July 2023, exactly 23rd day of transplantation. He was compliant to immunosuppression, and he mainly presented into the transplant OPD with right foot drop, which was acute in onset and rapid progression. There was no history of any trauma, backache, or addictions. And he was examined. His vitals were stable with normal BP and pulse rate. There was no pallor or any other signs except for tremors. Coming to the thorough systemic examination, cardiovascular system, respiratory system, and abdomen were normal, and CNS showed a right foot drop with power 1/5 of dorsiflexior group of muscles, with sensory loss around on the lateral aspect of the foot, with normal ankle jerk. And I would like to share the video of that foot drop.
Your screen is not moving.
So he been presented with right foot drop with high stepping gait. The left foot was normal. And he was investigated, and his lab parameters were as this. He had hyponatremia, hyperkalemia with hypochloremia. His HbA1c levels were around 5.1, and the fasting blood sugars were 105.
Dr. Niranjan, your slides are not moving. Yeah.
And his lab parameters were as such. He had hyponatremia, hyperkalemia with hypochloremia. His HbA1c levels were 5.1. And he was looked for any other causes of peripheral neuropathy. ANCA being negative, anti-DS being negative, C3, C4 levels were normal. Viral markers were negative. And coming to his TAC levels were 16.2 nanogram per level, and vitamin B folate levels were done to rule out other causes of peripheral neuropathy. And now conduction studies was done and was showing sensory motor axonal neuropathy of common peroneal, right common peroneal nerve. And MRI brain and whole spine screening was done, which was normal. And this was the NCS study report, which showed sensory motor axonal neuropathy of the common peroneal nerve. And with the above history and the investigations, peripheral neuropathy secondary to TAC toxicity was suspected, as the patient had hyponatremia, hyperkalemia with elevated TAC levels and with neuropathy. And the TAC dose was reduced by 25%. Initially, he was given around 5.5 mg per day, and it was reduced to 4.5 mg. And physiotherapy was advised. There was 50% improvement in symptoms over 3 days. And exactly after 1 week, these were the following investigations. We had improvement in, there was improvement in sodium levels, potassium levels, and the TAC levels were 12.2 nanogram per ml, which was reduced from 16 to 12.2 nanogram per ml. This is the summary. So he was a 47-year-old male, known case of CKD in nativity. This is being presumed DKD. It was a live-related renal transplantation, which was done in June 2023. It was an immediate graft function on triple immunosuppression. The ATG as the induction therapy, and he presented on post-operative day 23 with right foot drop. And he was evaluated for other causes of peripheral neuropathy, which was ruled out, and he had an elevated TAC level. With elevated TAC levels and with his blood parameters being hyponatremia, hyperkalemia, TAC toxicity was suspected, and the TAC dose was reduced, and there was a significant improvement in symptoms. So the peripheral neuropathy was attributed to TAC. So coming to the discussion, the exact mechanism of foot drop involving common peroneal with respect to TAC is still not known. The pathogenesis may correspond to the lesions in local white matter secondary to ischemia or hyperphagia. And the risk factors being seizures, cerebrovascular diseases, hypertension, hypocholesterolemia, IV methylprednisolone, hypomagnesemia, and high CNI levels. Our patient had a past history of hypertension, and he was also being diabetic. So more likely to affect from the neurotoxicity from the CNI, and the CNI levels were high. So the risk of neurotoxicity from tacrolimus may vary according to the type of solid organ transplantation. Lung and liver transplantation were more common, because in these cases, TAC doses will be very high due to high immunosuppression to be needed. And our patient had hyperkalemia, hyponatremia with peripheral neuropathy with elevated TAC levels, all of which improved with reduction in TAC dose. So these were the related articles which I found out. So one case was tacrolimus induced encephalopathy and polyneuropathy in renal transplant. It was a 47-year-old male with live related renal transplantation with mother donor with haplomatch, and Basilix was the induction therapy. Exactly after 2 months, he had encephalopathy and polyneuropathy, and his TAC levels were related. In this case, they have stopped the TAC and switch out to cyclosporin. Initially, TAC doses were reduced, and there was no improvement. So TAC was converted to cyclosporin, and the patient had a significant improvement in the symptoms. And another study was that unilateral common peroneal nerve palsy. He was a 52-year-old male who underwent live-related renal transplantation, and he had received the mother was the donor, and it was an haplomatch. Induction therapy was not given in this case, and he had peripheral neuropathy, that is right common peroneal nerve was involved in this case. And in this case, he presented around 40 days of transplantation, and with reduction in the TAC dose, the patient had a significant improvement in the symptoms within 1 week. Another case was thrombotic microangiopathy with peripheral nerve. Here also the patient had bilateral common peroneal nerve involvement with thrombotic microangiopathy. In this case, they have stopped it with reduction in TAC. It did not show any improvement, so they stopped the TAC and introduced cyclosporin, which showed significant improvement in the neuropathy. And other case was late onset tacrolimus induced polyneuropathy in a kidney transplant recipient patient, where here it was also live related renal transplantation, but here the presentation almost 6 years of the transplant, the patient presented with polyneuropathy, which also improved with conversion of tacrolimus to cyclosporin. Thank you.
Thank you, Dr. Niranjan, for your presentation. And regarding it's a rare scenario to get a renal neurotoxicity from tacrolimus, though you have a 30% of tacrolimus can cause, first patients can cause neurological symptoms, and peripheral neuropathy is somewhat very rare to have. I too have the number of 6 patients of TAC-induced neuropathy. 2 of them had a immediate starting TAC and had a series of 6 patients. So it reduces it makes a membrane, it increases membrane depolarization of the nerves, that by causing the decreased action potential of the nerves, causing the neuropathy mechanisms that were suggested. And only thing, we have to reduce the tacrolimus and you have to switch on to that cyclosporin. Another one thing, so before elucidating into that tacrolimus-induced neurotoxicity, you have to still look for vitamin B12 deficiencies and other causes of inflammatory neuropathies also to be ruled out. Panelists, your comments, please.
Good presentation, Dr. Niranjan. How would you differentiate from diabetic neuropathy and diabetes-induced peripheral neuropathy? Foot drop.
Sir, in this case, the patient was euglycemic at the start of initiation of dialysis, and usually during the post-transplant phase, the HbA1c levels were done, which was normal, and even that sugars were, even fasting blood sugars and postprandial blood sugars were normal. So only positive was his TAC levels were elevated, so we attributed it to TAC-induced polyneuropathy.
And rapid improvement after reducing the dose.
After
was the patient had a neuropathy before transplant?
No, sir, he did not have any, as such, there was no documented evidence, but he was complaining of mild tingling and numbness. As nerve condition studies was not done prior to transplant.
Dr. Pradix?
I thank you for your nice presentation, rare complications of tacrolimus. I agree with Dr. Vishwanath that this is a diabetic patient and he developed neuropathy immediately post-operative, like the patients of diabetes may develop as a first beginning of this mononeuritis complex, the vasculitis mediated damage. And why don't you consider, because the patient is euglycemic because it is only 20th day in the post-transplant period. The HbA1c rest of the 2 months in the pre-operative dialysis phase. So HbA1c may be normal in this case, but we should consider this as a diabetes-induced damage, and that should be ruled out actually.
Okay.
Secondly, you told that there is evidence of a sensory motor axonal neuropathy. So if there is an axonal kind of damage, such a rapid improvement is not possible. Even you remove the culprit, even you remove the drug which is responsible, axonal regeneration is not that rapid. It is not the myelin, it regenerates rapidly. So these 2 small queries I do have. Most of the cases, tacrolimus toxicity, we get more of a bilateral symmetrical, or like a tremor, we can get a brace, we can get optic neuritis or seizures, or maybe a bilateral symmetrical neuropathy. So is a asymmetrical neuropathy is mostly related to the tacrolimus related vasculitis due to increase in thromboxane level into the vasa nerva, and that can cause, and that improves if you withdraw the drug, as you have told the other test reports. It's a part of a TMA in the peripheral nerve. So these are the small queries. Anyway, this case is very interesting and very nice.
Yes.
Thank you. The serum magnesium level was 0.7. Is that require any therapy? It was a question asked through this thing. And plasma cell dyscrasia, of course, it has to be ruled out in any presumed attack-induced neuropathy. And also, demyelinating neuropathy is also to be ruled out in case of symmetrical progressive attack-induced neuropathies.
But that nerve conduction study pattern was sensory motor axonal. There was a reduced compound muscle action potential, sir. As such, it was not demyelinating.
So it is your mononeuritis-like picture actually. It doesn't fit into AIDP, but generally if the patient is having the progressive symmetrical polyneuropathy with predominant motor symptoms, that too can happen with attack. You have to rule out all these things before attributing this to tacrolimus.
Tacrolimus.
Sir, any other comments from the panelist?
As you mentioned, it is commonly seen in liver transplant. We had one patient like this who had after pancreas and kidney transplant simultaneous severe foot drop. And in fact, after all these studies, we attributed it to diabetes, type 1 diabetes. And then we thought it is more of diabetic neuropathy induced worsening rather than tacrolimus. Tacrolimus levels are okay. So the first suspicion, as Pratik sir mentioned, should still go towards diabetes. And of course, after you rule out diabetes-related neuropathy, we should think of TAC, and here levels were higher. AADP, CADP, I have not seen much. I have seen one patient with GBS after transplant. This happened during the COVID time. Immediately after COVID came down, we transplanted him. After about 2 months, this man, took a vaccine. And then we don't know, we didn't want to make a noise because vaccine was needed.
Yeah.
But we felt probably, personally, I felt probably COVID vaccine related neuropathy developed. He improved with IVIG. It's almost now 2 years. He's doing well. That's the only thing I can think of. Yeah.
I think we have answered the questions and it's a good presentation. Actually, the patient's improvement of around 50% with reduction of TAC, does it favors more in favor of TAC-induced nephropathy? Like,
yes.
Can be. So I had few patients of neuropathy. Ultimately, were all non-diabetic actually recipients, 6 patients actually. 2 patients immediate post-transplant had a paresthesia all over the body actually. Could not make any other diagnosis. I just shifted into tacrolimus to cyclosporine. Immediately it got disappeared and patient was all right after that. He was on cyclosporine. And few patients developed a neuropathy, like mostly it's a motor neuropathy with sensory component. And all of them had a high TAC levels. Once the TAC levels get reduced, they had a significant improvement. It was been documented by nerve conduction studies also. So we do encounter attack-induced neurotoxic manifestations. And if there are no further questions, any comments, Pratik sir? Final comments?
I have a comment. This is an invitation for all of you. This is not related to the case. So this year we are doing this 33rd conference of ISOT in Kolkata, and that will be 5th to 8th October. We will be having interesting international faculties, including Professor Montgomery, Professor Mark Haas, a founder member of the PAMF, Professor Jonathan Barrett, and so many 15 to 20 international faculties. And we have got also these workshops on ABO-incompatible immunology, pathology, scientific writing. Professor Jeremy Chapman, Daniel Brannan, Hariharan, Susanthiran, everybody is coming. So I request all of you, please do come to Kolkata and enjoy this scientific. And thank you very much for inviting me.
Thank you for inviting.
Thank you, sir. Thank you for the invite, sir. So thank you. Many thanks to the speakers who have prepared the slides and presented to us to take a long time. And many thanks to the panelists who, in spite of the busy schedule, has come and shared their wonderful knowledge for us to refine ourselves in our practice. I thank the viewers who have, in spite of their work, was logged in and asked questions through the chat box, make the sessions more interesting. And I thank the MQ team for providing the technical support. And And this program will continue as ever. And it's the first Saturday of every month will be the program. And whether it rain or shine, it will be there. And we invite the other institutions to present interesting cases so that we can learn from them. Thank you, one and all, for the happy meeting.
Thank you. Bye. Good night. Have a good weekend.
Thank you, sir. Have a nice weekend. Thank you, sir. Thank you, Pradeep, sir.
Thank you.
Thank you, Arun. Thank you, Niranjan.
Thank you, sir. Good night, sir.
Good night.